The video series Glycemic Control was developed by the Georgia and Oklahoma Academies of Family Physicians as part of the Go Diabetes initiatives. The Glycemic Control series consists of 5 video vignettes, each outlining best practices in the care of diabetic patients. Please proceed to the registration page for more information on the approved number of prescribed credits for this activity as assigned by the American Academy of Family Physicians and AMA PRA Category 1 credit as assigned by the Georgia Academy of Family Physicians. Upon completion of each video vignette, please return to the Resources video page on the Go Diabetes website to complete the activity evaluation and earn your CME. This activity is supported in part by an educational grant from Sanofi Aventis. We thank you for participating in this online activity and hope it serves as a valuable educational tool.
These are the things that you and I think about when we start insulin. It's kind of like we're talking about pills. Well, they need insulin. Which one? Well, how much? How do I adjust it? And then, oh my goodness, how in the world do I teach this patient how to do it? And if I do need to change doses, well, how do I change a dose of insulin? And hopefully we'll answer all those for you as well. So let's start with just some sort of fundamental rules. These are indications that somebody needs to be on it. So it takes that question out of your mind. Number one, it's not contraindicated at any time, okay? So don't feel like that. It's not like metformin where they got an end-stage renal disease and I'm going to give them metformin. That'd be a contraindication. Well, not true with insulin. You're not going to kill anybody with insulin, generally speaking, unless they, have horrible hypoglycemia, which is very rare. Times to consider it as initial therapy. If they're having fasting glucoses above 250 or random glucoses above 300, that's a patient that really ought to be started on insulin. It's also recommended as an initial therapy when you have A1Cs that are above 10, or if somebody's catabolic, they have polyuria, polydipsia, weight loss, or if they have ketones. So this would be somebody, whether that could be a type 2, that could be a type 1, but anytime you see those symptoms in a diabetic that's catabolic, I lost 20 pounds over the last 3 months. Well, that patient needs insulin, okay? Your average diabetic is not going to come in with that complaint, but that's one that's going to have an A1C of 9 or 10 and with glucoses like I mentioned right there. So when you do start insulin, what are your options? Well, the first goal, it's similar to when you start pills. Your first goal is to normalize the fasting glucose. To normalize the fasting glucose, you need basal insulin, okay? And when I say normalize, I put the number 70 to 130, you could say 90 to 130, but somewhere in that range, that's what we're going to consider normal. The reason why we're using that normal or that range is because most patients if they get a fasting glucose to that level, they'll have A1Cs close to 7 or less, okay? And here's your simplest option, a once daily option, okay? You could start 10 units of probably 3 different kinds of insulin, or you could start out with 0.2 units per kilogram, okay? So remember, whichever one you want, 0.2 units per kilogram, probably a little bit better way to start, but if you I don't want to remember that, I just want to start with 10 units and go up, that's fine too, okay? And what you're going to do is if you're going to start with a basal insulin, such as Lantus or Levemir, you're going to give it once a day and see what their fasting glucoses are. And what I do is I give my patient instructions, check your blood sugar every morning when you get up. And then I want you to, if your blood sugar is above 130 when you get up, the next night I want you to go up by 2 units. And then I want to see you back in 2 weeks. And then eventually, by the time I see them, they may be at 25 units, they may be at 20 units or somewhere. I give them permission to titrate up, and I write this down for them, and we teach them, this is, when you start this, if your blood sugar when you get up tomorrow is 130, then stop. You keep your dose the same. If it's less than 70, go down by a few units as well. So there's different ways you can do that. You can go up 2 units every day, or you could go up 2 to 3 units every 3 days until you get to that range. If they're getting numbers less than 70, then have them decrease the dose by 3 units. But have that printed on a sheet of paper, and when you start insulin, if your most common thing is I start a basal insulin, we'll put down, blank, start, this insulin at this dose. You could write down the starting dose, test your blood sugar. They've got to be able to test their blood sugar to take insulin, okay? And if your blood sugar is between this number and this number, don't change the dose. If it's less than this number when you get up, decrease your dose by 3 units. If it's above this number, increase the dose by 3 units. And come back and see me in a couple of weeks. And then sometimes what I'll do is I'll give them a max dose. If you get to this dose, don't go above it, but give me a call as well. And that's a way that's been shown to be safe, and it's effective. And it keeps you from having to, the patient waiting to see you every, whatever frequency to make dosage changes. So we're talking about once daily dosing, and here's some examples of once daily insulin options. You all are familiar with many of these. Some of them you might not be as familiar with, but Glargine is Lantus, Detamir is Levemir, Premix 70-30 or Premix 75-25. What that means is it's 70% of intermediate acting, and it's 30% of very rapid acting, or in this one it's 75% of an intermediate acting, where it's got like a 6 to 8 hour time frame, onset of actions about 2 to 3 hours, and we're going to look at that in just a second. Here's some advantages and disadvantages. For Glargine, advantages, there's no peak, there's less low blood sugar and less weight gain, and it is simple. It's so much simpler than having somebody mix insulins and do all those kinds of things. Disadvantages, you can't mix it because the pH of Glargine is about 4. When you inject it, the reason it works like it does is it's injected, it's a hexamer. The molecules are all stuck together in groups of 6, and as that pH normalizes, then the hexamers kind of break loose and become monomers, and the monomers can be absorbed into the bloodstream. But you can't mix it with other kinds of insulin. And there's no mealtime coverage. This really only affects preprandial and fasting blood sugars. All right. Detamir or Levemir is very similar. It does probably have a little bit of a peak. You can't mix it either. It's a basal only. Disadvantages compared to this one, it probably has a little bit shorter duration, and so a lot of people will dose this one twice a day, whereas most people can dose this Glargine once a day. Having said that, you can dose Detamir once a day too, okay? The advantage of 70-30, you get some basal coverage and you also get some mealtime coverage. This 30% of the whatever is in it, whether it's Humalog or Novolog, it covers meals. And so advantages of that, you get some mealtime as well as basal insulin. The disadvantages of this compared to these two is you get more low blood sugar. Basically with any insulin, if it makes your blood sugar go down more, you're going to have more weight gain and more low blood sugar. And if the opposites, if somebody says, well, we have less weight gain and less hypoglycemia, and they say, well, you also have less blood sugar lowering too. It's just, they all have that trade-off. Yeah?
Since Glargine is QD, is there any preference to QHS versus QAM dosing? I've seen that, with the timing of the onset of action, since it's peakless, I've heard different things.
I think generally speaking, no. A few caveats to that. I think if you have a type 1, there was a study done that recently showed that type 1s who take Glargine have less low blood sugar if they take their Glargine in the morning as opposed to taking it at bedtime. And you can kind of understand why, because if it does kind of wear off a little bit, it's going to be wearing off at about 7 or 8 a.m. versus, wearing off at 9 or 10 p.m. And so that's the one thing I would say if it's a type 1, then I might consider having them dose their Glargine. The thing about bedtime that's nice is that's usually fairly consistent for most people, whereas getting up is less consistent for some reason for people, I think is a thought. But aside from that, I know that there's big advantage or disadvantage either way.
Is there any advantage of using BID dosing? And sometimes the patients will do that on their own, or I'll see other providers do that.
With Glargine?
Glargine.
Some people, and this is not in the PI, I don't think, for Glargine, but once you reach a certain dose, the thought that if you inject 60 units of Glargine in this big depot, of insulin sub-Q, does it get broken down as predictably as what 20 or 30 units does? And so they may say, well, but it's kind of arbitrary and I don't think it's real scientific. It's not wrong either, though. So it just adds an injection a day. I think what I do in that case is if somebody's having some issues with it, then I might have them, like they're taking 70 units a day, I might say, why don't you split that up and let's see what your blood sugars do over the next week. And if it seems to make a difference, great. If it doesn't, then go back to once a day.